Good evening, everyone.
Okay.
Yeah, anyone can take up this. Who is going to read this? Anybody can do that.
Yes, sir.
You,
Sir,
you announce your name and start it.
So it's John Caesar. So a 28-year-old female came with complaints of limping over the right side for the past 17 years. Pain in the right hip is on and off in nature for the last 3 years, and she also gives history of difficulty in sitting cross-legged and squatting. And there's a gradual progressive deformity in the knee during adolescence.
Yes. Yeah, go on.
Okay. Yeah. Further, she also says the pain in the right hip started while she was 11 years old. Skin traction was applied for 3 weeks, following which the pain subsided, but it recurred later. She had consulted a local hospital, and surgery was done, and she was put in a spica cast for 6 weeks, and she started walking 3 months later. And she noticed a limp after the 3 months, and she was using a shoe race since then.
Slide next. Okay, you go back. So, Jonesy, you have the history here. You know, what is in your mind when you have heard this history? What way your mind works now?
So definitely the pathology is in the hip, and she had undergone
a surgery.
Okay.
So what possible is the diagnosis, pathology at that point of time, which warrant 11-year-old, which warrant a surgery and immobilization in spica?
So I'm thinking of possibly Perthes.
Why Perthes?
Traction was given, and also a surgery to probably contain the head.
But why can't this be a fracture, an ecophyma?
Ecophyma fracture. There's no trauma as such which she had told.
Yeah, there is no history of trauma given as it is, right? And in that age group, if you want to get a fracture ecophyma, it's usually high velocity injury. There is no history like. So is there a condition which is not traumatic but can behave in the same way? No, 11-year-old girl. Yeah. Which other condition? You know, there are only 2 conditions which come there, no?
So the other one I was thinking was Skiffy, but I'm not sure of Skiffy.
Why you say that it is not so? From the history.
Yes.
Shyam, how do you? What is your point against Skiffy in this particular case? Capital femoral epiphysis is better that way. Do you think that the diagnosis is Perthes or slip? You know, as from the history, you have not seen the patient, you have not seen anything examined.
Yes, sir. Sir, considering this history, my initial first diagnosis will be as Skiffy only.
Okay. Why not tuberculosis?
Tuberculosis, the child did not have any other constitutional symptoms like fever or evening rise of temperatures or any contacts in the family. Sir.
Yeah, but this is how many years back it has happened, no?
Years back, yes.
So they may not get a proper history. So we have to consider all these possibilities when you have on the history. Because for tuberculosis also surgery can be done. A spica can be given, right? And she can walk limping.
Possible reason for the skin traction.
Yes, sorry.
The possible reason for the skin traction which was put.
Initially, you can give skin traction. In Perthes also can give. When will you give traction in Perthes before surgery? Suppose, let us take that this was a case of Perthes disease. Why skin traction was given? Anybody can answer. It need not be John C. or Shyam.
Sir, considering the age, if the age was less than 5 years.
No, I didn't get you.
The age, sir, if the age is less than 5 years, we can consider.
This is 11 years. We are talking about 11-year-old girl coming with a hip problem. The surgeon gives traction for 3 weeks and surgery was done. And patient was put in plaster for 6 weeks. That is a history. So imagine that this was a case of Perthes disease. Why skin traction was given for 3 weeks? That is the question that I am asking. Anybody can answer that question, because this is a very common problem that we get, and especially for not for the OSCE level. This is the long case for all the MS students who will have exam for MS. This is the long case, and typical long case for postgraduates. So all these questions will come there.
So if for containment, sir, if the epiphyseal involvement was not much, it was less than half.
Yes.
So then we can consider we can give non-surgical.
No, that is different. Why in this particular case? Talk about this case. In this case, or in a case of Perthes disease, why traction needed to be given? That's a question that is asked.
So to relieve
the spasm, sir.
So why should you relieve the spasm?
Prevent the expulsion.
You are far away from this case. No, the answer is, if there is a stiff hip, if the surgery is done for containment, we are talking about containment surgery, and if it is stiff hip, how can you contain it? So before containment, what is the prerequisite?
The movement has to be used.
Which movement?
Yes, sir.
Which movement do you need?
Internal rotation.
Internal
abduction.
So, abduction.
You need abduction. How? You need abduction. So what is the classical deformity in Perthes disease?
Flexion.
Abduction, internal rotation deformity.
Adduction and external rotation.
Abduction, internal rotation deformity.
Abduction.
Internal rotation deformity.
Abduction, internal rotation deformity.
Flexion, adduction, and external rotation deformity.
Why the person said abduction deformity and internal rotation deformity? What is the reason in Perthes disease to get such deformity?
So in Perthes there is loss of abduction.
Just to make you understand that the deformity is not abduction. Can you get abduction? External rotation deformity. Internal rotation deformity in abduction. Internal rotation is possible in 2 cases actually. Which are the 2 situations where you get internal rotation deformity?
So late stage of TB.
Huh? No, I'm not getting it. Okay.
The late stage of TB, so tuberculosis.
Late stage of tuberculosis. Okay. Then what is that late stage? There is nothing like a late stage. You have to mention the classical staging of tuberculosis. Huh?
One.
What are the three stages?
Stage of synovitis.
Stage of synovitis.
Stage of early arthritis.
Yeah.
Late arthritis and advanced and
Advanced. All these things are, you have to, once a discussion is happening here, I always tell you, go back and read. These are all there in DAS, you have to read that. And even what is the early in arthritis phase Shyam was talking about? I think Shyam was talking about, right? What is the deformity in early arthritic phase in tuberculosis?
so it is
It is
flexion,
abduction, external rotation.
flexion, adduction, external rotation.
Flexion, adduction, external rotation. Okay. Is it? Check. Then what will happen in advanced situation?
Sir, internal rotation will happen, sir.
Why internal rotation happens in tuberculosis?
so because of
the patient prefer to lie on the opposite side with the affected hip on the top, and that keeps that limb adducted and interrotated.
Correct. That is the answer for it. Then, is there a situation in tuberculosis where there can be an external rotation?
Yes, sir. If the patient is kept on interaction for prolonged time.
Or what you can say is treatment modified. Okay. Is there any other reason?
Dislocated.
What is the factor which is holding the hip in internal rotation? When it is destroyed, the hip loses that position. What is that structure? Iliofemoral ligament.
Ligament.
Yeah, Bigillus ligament. So what is that dislocation known as? That is called everted dislocation. So it can go into external rotation. So treatment can modify it. Number one, progressive destruction can also modify this. That is the answer. Anyway, we were moving a little bit away from because there was a comment on the position. In Perthes disease, what is classical? Classical.
Flexion, adduction, external rotation.
Flexion, adduction, external rotation. Okay. What is the deformity in slip capitulofemoral epiphysis?
Abduction, rotation.
External rotation.
External rotation.
Adduction and extension.
Repeat.
External rotation, adduction, and extension deformities.
Extension deformity. How many cases of extension deformity you have seen, or is it true? It is possible, but what you have to say answer is extension deformity you cannot make out easily, right? There may be an increased extension. That is all. Extension deformity what is when you talk about a deformity, it means that you cannot bring back to neutral position.
Yes.
Yeah. So there may be flexion deformity may not be there. That is all. So you can't say that there is an extension deformity. What you should say is there is external rotation and adduction deformity. So what is the difference? In Perthes also there is adduction and external rotation deformity. In slip also there is adduction and external rotation. What is the difference? The difference is in Perthes disease, adduction deformity is the predominant deformity, whereas in slip, it is external rotation deformity which is predominant. That is it. There is a difference between these two. And flexion deformity may or may not be there in a case of slip.
Okay.
That should be your answer. Your answer should be very, very clear. You should learn how to answer these questions. In tuberculosis, flexion, adduction, internal rotation is the deformity. Usually. But unless the treatment modified. There are two conditions. One is tuberculosis. And the other one will be a posterior dislocation of the hip where you have got flexion, adduction, internal rotation deformity. So we should not, we should understand when a deformity is there, it points to a particular disease. So you should understand what is the difference between each condition which you are talking about. Okay. Then our point was why skin traction was given. Okay, skin traction was given. You see, if you want to contain the hip in a Perthes disease, you need movement. So the reduction in movement or the stiffness in the hip in the early phase of the disease is basically because of spasm or because of soft tissue contraction, most often spasm. So this can be reduced by traction. If suppose you can't reduce or you can't get this movement, then what will you do? By skin traction, you are not getting abduction. Then what will you do? The answer is you have to put a spica. Okay. You have to give a spica, and this spica will be given in extension, in abduction. So this gradually you can increase it also. These are all things what we did when we were students. Nowadays it is not done. But somebody, senior teachers can ask you this question because we need abduction 30 degrees minimum to contain the hip by a varus osteotomy. Okay, other osteotomies, you don't need that. If there is a stiff hip, you can go for other methods. But movement is very, very important. Okay, we'll further go to the next slide. Then surgery was done and hip spike was given for 6 weeks. Here, what is the possibility? Is it for Perthes or with slip that we do it? Usually if you do a varus osteotomy on the femur to contain the hip, we have to immobilize. And that is usually 6 weeks. Equally possible in a slip if you are doing certain surgeries like Southwick's surgery. So there also subtraumatic osteotomy is done and fixation is done to reposition the head. Then in that situation also spica cast is given. So this is possible in either situation. Okay. So now we'll go to the next slide. Okay. You see the patient, how the patient is walking. What type of gait is this? That is the only flexion that she can have. That is what you have seen. Okay. What type of surgery? What type of gait is this? Suppose you are describing this in the exam. How will you describe this? Is there another? Naomi, can you describe this gait? Or you just describe, don't talk about the what type of gait it is. Just describe the gait.
Okay.
Sir, bipedal, biphasic, unaided gait with left shoulder dropping down with the right knee and hip flexed, probably short limb gait.
Short limb gait. I think it will make confusion for you. See, I just want to tell you how you actually talk about gait. You just use these words in the exam, right? This patient is limping. Okay. Where does she, on which side she's limping? On the right side. She's limping. And what has happened? What is happening to the shoulder? Shoulder is moving to one direction, right? Which direction it is? Not very, very evident in this case, right? But usually she's tilting her shoulder to the opposite, to the left side, right? Right. Then what is the distance between the two heel strike, or what we call step length? It is equal, right?
Yes, sir.
And she's bearing weight equally, only equal duration on both sides. Yes?
Yes.
Yes, she's bearing equal weight. So what does it tell you? Is it a painful gait or a painless gait? The why I ask this is most often when patient complains of pain in the hip, you will say that this is an antalgic gait or a painful gait. It is not true. See, if you want to say that it's a painful gait, you have to see that you are lurching to the same side, number one. The stance waist should be short and the step length should be asymmetrical. You understand? So these are the features if you want to talk about painful hip or antalgic limb. Without that, if you are talking about this is an antalgic limb, no, you should not. So this is a situation where the patient is not having a painful limb, but he has got a limb. So what are the other possibilities? Common things. There are so many possibilities. Common things that examiner expect from you is one is short limb gait and the other one is a Trendelenburg gait. Yeah. Huh? Sorry?
So you meant painless limb, sir?
No, I didn't get you. Please.
Painless limb, sir?
Yeah, painless limb. Which are the common painless limb that we have? No, that is the condition we are talking about. We are talking about this.
Short limb gait and Trendelenburg.
Yeah, usually short limb gait and Trendelenburg gait. There are so many other gaits. I'm not talking about that. But these are the two ones usually you get in an exam. If you want to say this is a short limb gait, when you step on that side, your shoulder should dip down.
To the same side.
Yeah, it is dipping down is not tilting to that side. Okay. When your shoulder is tilting to one side, you say it is lurch. Can you see me? Can you see me moving?
Yes, sir.
Yeah, yes, sir. I will lurch like that. The other one in short gait, what happens is I dip like this. I'm showing both shoulders because I cannot push down both my shoulders. So I'm showing you this is like this only, not like this. So this is the basic difference between a short limb and you just remove one of your shoes. Okay. Then you start walking. You remove one shoe and start walking. The typical gait of short limb gait you can see. You ask your friend to remove the shoe and walk. So that is the classical one. See, that is classical short limb. You understand? So you have to find out which limb it is, and examiner will ask you what are the parameters on which you made this decision. Okay. In a Trendelenburg gait, what is happening? The mechanism of abduction mechanism is not working. So what will happen? When you bear weight on that side, the patient will fall to opposite side or tilt the body to the opposite side. To prevent that fall, he lurches to the same side. So in a Trendelenburg gait, patient lurches to the same side of lesion with equal step length and symmetrical step length and equal step length. The answer for a definition. Because these questions will be asked. That is why I am telling you this. We should not discuss too much about it. There are only 3 points to remember. It's not a very big thing for you to remember. But if you are confused, your answer will always go wrong. What happens in an antalgic limb? There also, the lurch is to the same side.
side.
Lurch is to the same side, not to the opposite side. Opposite side lurch happens only when uncompensated Trendelenburg side. Uncompensated Trendelenburg, if it is happening. So suppose you are standing on one side of the damaged side and you are walking, you are bearing weight on that side. Your body goes to opposite side. When does it happen? It can happen. That is called uncompensated Trendelenburg. In a very mild weakness, very mild Coxa-Vara, this can happen. You need not tilt to the same side. It may not be very obvious, but when if you observe it, you can make it out. But that is not the usual case in the exam. Exam case, classical Trendelenburg means lurch to the same side, equal step length, and weight bearing. That is, stance phase is equal and step length is symmetrical. 3 points only. Antalgic limb. Lurch to the same side. Use only these words. Don't use lurch to stance phase is not equal and the step length is asymmetrical. It is rare to get such a case, but examiner will ask you this case. Most often it's either Trendelenburg, short limb, or sometimes even a combination of both. Trendelenburg plus short limb. Here it becomes a little difficult. So it is better that if you have the lurch towards that side, and then it's better to say that it is Trendelenburg gait. That's better that way. Because otherwise there can be a little bit of confusion. Because if suppose the patient has got a congenital shortening of the femur or tibia, there is no problem in the hip. This patient also is limping. That will be the classical situation of a short limb gait. But most often the hip problems, even when there is shortening, patient will have a Trendelenburg component to this. So always in the safe way to put it in the exam is looks like Trendelenburg gait. That is better way to escape from the examination. So I think I have given you 3 scenarios. Is it very clear? Any doubt in this particular? I think it is clear. Okay, we'll go further. Okay, now somebody asked now me or who is John C. Okay, John C, you just inspection findings, you can just look at it and tell us.
Yes, the patient was examined in supine position, and the lower limb is there is a valgus deformity at the knee, sir, with and on flexion of the knee there is a posterior lag sign, sag sign, which is seen.
Okay.
And also there is a limb length shortening on the right side, which can be known.
Correct. So there is shortening, obviously. There is valgus deformity, and there is a posterior subluxation of the
Tibia.
knee. Correct. Tibia. Posterior. That's all what you can make out. Okay. So there is a clinical finding in this particular case. Okay. Then is there a rotation deformity?
Also, sir.
Huh?
Looks like there is some wasting also, but not very clear.
Yeah, there is the wasting, and look at the knee patella now.
Yeah. Yes,
is there external rotation?
Yes, there is.
Yeah, no, this only this much you can be shown in this diagrams. In a clinical examination, it is quite different. When you are presenting a clinical examination inspection, it's not the same. But these are the findings here. Okay. So each patient had a linear scar of 6 centimeters on the lateral aspect of the trochanter. Okay, this can be, we are talking about a surgery which was done. And we don't know actually what was the surgery. And as it is, John C. said that it is a surgery for containment. Is it? Everyone agree to that? And the diagnosis for this? We don't know. We don't know. Possible.
That could be
so many years back. Right. So now read this.
Yes, sir. The lumbar lordosis was exaggerated. And,
So what does it tell you? What does it tell you?
There is a compensation which is done in the spine, sir.
Or in other words?
Flexion deformity.
There is a fixed flexion deformity. Whenever you talk about these type of things, the question asked is with very, very specific. The lumbar is exaggerated. What does it mean? Sir, there is a fixed flexion deformity of the hip.
Yes, sir.
That should be your answer. Not just flexion deformity. Then you will ask about is it fixed or not. That question comes. It should not be. Okay, next.
The anterior superior iliac spine is at a higher level on the right side.
So what does it tell you?
An adduction deformity or coronal plane deformity is there.
Yeah, coronal plane deformity is there. Right? Here, the, okay. Which side is involved?
Right side. Right side.
Right side. So anterior superior iliac spine is at a higher level. So what does it tell you?
Adduction.
Reduction deformity.
Adduction deformity. Why there is an adduction deformity? In adduction deformity, anterior superior iliac spine is elevated.
Sir, can I answer?
Yeah, anybody can answer. No, just waiting. Don't waste. You can go on answering. Even if it is a wrong answer, doesn't matter. So that is why we are discussing these things. So you'll correct all these wrong answers. Wrong answers are more welcome than right answers. Okay.
In case of an adduction deformity, there will be an apparent lengthening. To compensate this, anterior superior iliac spine to the same side will go up, sir.
Everyone agree to this statement? Come on, fast.
Yes, sir. So in an adduction deformity, the leg appears to be lengthened. So the pelvis will tilt upwards to level the foot and to paralyze the shoulders.
Sham is talking. Am I right?
Yes, sir.
Sham, in an adduction deformity, what happens? Forget about the compensations. In an adduction deformity, what happens?
Abduction is restricted.
Abduction is not there. When there is a fixed adduction deformity, abduction is not there. That means if it is the limb is going to the opposite side, it will overlap the other limb, right? Okay. So how can you walk with limb overlapping? So you have to compensate that. How will you compensate that? No, the answer is not correct. The answer which was given.
Tilt the pelvis.
You will tilt the pelvis in which direction?
And the
opposite.
Make the affected side more proximal.
You will elevate that side of the pelvis upwards.
Yes.
That is the answer, right? Till something happens. Till what happens?
Till limbs are parallel.
Will the limbs are parallel? Then only you can walk. So what happens? Anterior superior iliac spine, when you palpate, it will be at a higher level. Correct?
Yes.
Okay. So will it produce lengthening or shortening?
Shortening.
It will
Produce shortening. So there is apparent shortening that happens because of this compensation. So this patient has a adduction deformity. This patient has fixed adduction deformity. This patient has got a fixed flexion deformity. Okay, and this patient go on next.
There is a tenderness in the anterior joint line, and the trochanter is thickened, and there is a proximal migration of the trochanter.
Okay, so tender anterior joint line. What is anterior joint line?
Inferior to mid-inguinal part.
1.5 centimeter inferior and lateral to the mid-inguinal plane.
Mid-inguinal plane. Is it middle of inguinal ligament or mid-inguinal? Is it same?
No.
What is the difference?
No, sir. Not safe.
What is the difference?
Mid-inguinal point is between the ASH and the pubic symphysis. The midpoint of inguinal ligament is between the pubic tubercle and the AS.
Right. Then the next finding is trochanter is thickened. Okay. Why trochanter is thickened? What are the conditions where you get thickening of trochanter?
Malunited trochanteric fracture, sir.
Yes.
Infections.
Infections, yes.
This is sequelae of septic arthritis.
Infection. Then
Perthes.
Perthes is another condition. Anything else?
Coxa vara, trochanteric overgrowth.
Coxa vara and DDH. Okay. DDH, where the trochanter is pulled by the abductors. What type of epiphysis is trochanteric epiphysis?
Positional.
No.
Tractional.
It is traction epiphysis. So, what are the types of epiphysis you know? What are the other types of epiphysis? How do you classify epiphysis? You said this is a traction epiphysis. That means there must be some other type of epiphysis. What are the other type of epiphysis?
Epiphysis.
Pressure. Talk loud, confidently. Whether right or wrong doesn't matter. You be confident.
Pressure epiphysis.
Pressure epiphysis. What is pressure epiphysis? Why it is called pressure epiphysis?
Ends of long bone.
Yeah, most of the weight-bearing bones, you have got pressure epiphysis because pressure is the stimulus. That is the reason. You know, when you get a polio case, these questions will come to you. Understand? Because the limb muscle is not acting, weight bearing is not happening, this limb becomes short. Why in polio it is a paralytic disease? Why the limb is becoming short? That question you will be answering like this only. If you know this, this is because of the absence of pressure or stimulus to the epiphysis. A weight-bearing bone that is not happening. So traction epiphysis is otherwise called by another name. What is that?
Apophysis.
That is called apophysis. Okay. So the third one is atavistic epiphysis. We'll not go further on this. So thickening can happen in Perthes disease. Why in Perthes disease trochanter becomes thickened?
Hyperemia.
Osteonecrosis to the femoral head. So,
osteonecrosis to what?
Sir, in case of advanced Perthes disease, there will develop secondary osteoarthritic changes,
yes.
And it will eventually causes degenerative changes in the trochanter also.
Degenerative changes in the trochanter. Trochanter is not a joint, right? You know, this is because of the abnormal pull. That's one. Right. Then second is the hyperemia. Because the revascularization process happens and there will be around that area, there will be hyperemia. That also induces the growth of the trochanter. And varus deformity, when the patient is developing, the pull becomes more on the apophysis and this grows further. Thickening is because of hyperemia. The overgrowth is because of the traction. That's the answer. Okay, that is why it is proximally migrated. Yes, read that.
Checking the hip range of movement, there was a fixed flexion deformity of 15 degrees with a further free flexion up to 90 degrees. And there was an adduction deformity of fixed adduction deformity of 10 degrees with further adduction up to 20 degrees, and a fixed external rotation of 20 degrees with free flexion up to
discovered.
It's a rotation of 20 degrees with 10 degrees of further external rotation in flexion and 20 degrees in extension.
So reading this, examining this patient, and you find this, these are the findings of movement, and what is how can you interpret these findings?
Differential rotation.
That is one. What does it tell you?
Head is deformed.
Deformed head. Head deformed.
Head is deformed, exactly. So there is a deformation of the head that has happened in this particular case. Then fixed flexion deformity of 15 degrees. It explains why. What is it? What does it explain? It explains your inspection finding.
Yes, sir. Exaggerated lordosis.
Elevated ASIS.
Exaggerated lordosis. There is adduction deformity of 10 degrees. What does it tell you? What does it explain? Your inspection finding?
ASIS at higher level.
Anterior superior spine elevation. Okay. Then we have seen that there is an external rotation deformity that cannot be compensated. So always it will be revealed. Okay, next. So this was the finding. There was an apparent shortening of 4 centimeter and true shortening of 3 centimeter. Again, interpret that. How do you measure for apparent shortening?
From the xiphisternum to the medial malleolus with the limb and parallel, sir.
Exactly. Use only that word that you should understand. You should not forget that. Limbs in parallel position, you measure from a central point to the medial malleolus. Then how do you measure for the true shortening?
True shortening is measured by after
Firing.
sparing the
Square.
Okay. How do you square?
The other limb is brought to the same deformity of the same coronal plane deformity of the same limbs.
How do you do that?
Orthopical.
How do you do that?
Making the anterior and superior iliac spine at the same level.
Yeah. How do you do that?
Exaggerated the same deformity. Exaggerate the same deformity.
Exaggerate the
Same deformity.
So here anterior superior iliac spine is elevated. So to bring it, what to do with the limb?
Further adduct.
Further adduct. Further adduct till
it reaches the opposite ASI. Become
both ASIS same level.
What is that same level means? That is not
pelvis is level. Pelvis is level. Pelvis is level.
Level means what?
Perpendicular to the midline.
Answer should be like this. Till the line connecting the two anterior superior iliac spine become perpendicular to the mid-axis of the body. That is correct. The line connecting the anterior superior iliac spines is brought perpendicular to the mid-axis of the body. That is squaring. If somebody asks you what is squaring, these are all questions in the exam. So you should learn the same language and same words and sentences so that nobody will argue against. If you are just going same level means what? So is it the horizontal level or is it in the coronal plane? It's in the sagittal plane. So many questions will come to you. Why you unnecessarily land in trouble? Okay. So again, apparent shortening is 4 centimeters. True shortening is 3 centimeters. What does it tell you? Again, one more point that you can detect from this. What is that?
10 degree flexion deformity.
No.
Adduction deformity of 10 degree.
There is adduction deformity of 10 degree which is compensated. That is the answer. Okay, right. Then which special test is likely to be positive here? Which are the special tests that you do in a hip disease?
Trendelenburg test.
Trendelenburg and telescoping, right? These are the two cases, the two routine special tests that we do. Right. So in this case, which is likely to be positive? Which test you think that it will work?
Trendelenburg
test.
Why?
Proximal migration of
liver arm.
So in the examination, yeah, what are you talking about?
Abductor will be weak.
No, I didn't get you. That's all true. But I am asking in this particular case.
They can
The
be false
patient is having Trendelenburg gait. So she must have Trendelenburg test positive.
Okay. So what is the parameter that you need? Which has got a significance in doing this test? The answer should be, sir, in this particular case, I will not do a Trendelenburg test because it doesn't have a because it has a fixed adduction. So there is no meaning in doing that. So when you have got a fixed abduction or reaction deformity, you can say that I didn't do that because it has no significance. That should be your answer. You understood what I said? Did not understand?
Yes, sir.
You got the point?
Yes, sir.
Yeah. So when there is a fixed reduction or abduction deformity, you need not do that. You can say that it has no significance. Okay. Whereas false or true is not needed. Actually, that should be your argument. Okay. Then what is the clinical diagnosis now? With all those findings. The knee clinical examination I didn't add here. Clinical examination, no instability for the patient. And you can see that there is a deformity in the upper tibia on clinical examination. Okay. The patella is slightly laterally. That is all. So what is the diagnosis now? Most possibly. So from the history, we were thinking about the possibility of Perthes disease. Slip was also in our mind. In the clinical examination, there is fixed flexion deformity, there is fixed adduction deformity, and external rotation deformity. Yes, there is shortening. There is trochanteric overgrowth and thickening. With all these findings, which one will fit in? Perthes is possible. That is all what we can say. It's a clinical diagnosis. So is there any differential diagnosis for you?
Tuberculosis.
Yeah, you can give diagnosis even though if you feel that your diagnosis Perthes, there are points against it. What is the important point against it? That's the age group, right?
Yes, sir. Age is not.
Yeah, 11 years is not the classical age in which you can experience disease. That is the reason why you need a differential diagnosis. Understood? If this patient had a 9-year-old, 8-year-old, and then we are having all these processes, then we can think about Perthes disease. Also, you have to think about, because of the deformity in the knee, because of the deformity, think about
epiphyseal dysplasia.
Dysplasias also you have to think about. This should come. Of course, this will go when you see the X-ray, but this also should come to your mind because multiple deformities are there. Knee is also involved. How can you explain the knee involvement and valgus deformity in Perthes disease? It is not easy, right? It is not easy. Okay. Now what will you do now?
I would like to investigate the patient with imaging, sir, with X-rays.
Yeah, we will show you the X-rays.
So one doubt, sir.
Yeah. Yes.
Though we will ask for imaging, should we say about laboratory investigations?
Yeah, definitely, 100%. You should go for blood investigations and X-ray. That is the basic thing that we do. Definitely, you have to. Yeah, every time. Nobody will argue against this. Okay, now we are seeing the X-ray. What do you think it is?
It is deformed, sir.
Yeah, head is deformed. You describe the head.
Coxa magna, breva, and breva and trochanteric overgrowths.
This is a plain X-ray of the mature person with there is a proximal.
When you are describing a X-ray, you first thing is what is a plain X-ray of pelvis with both hips AP view. That's the first thing that you should mention. Then you start from the joint and go to the periphery, or from the periphery to the joint. So here it's better to start from the joint. Okay. So talk about the joint first, then talk about the head, then talk about the neck, then talk about the trochanter. Then you go to the acetabulum. So this will be a systematic way of presenting it. Yes, Jonesy, you now try.
It's a plain X-ray of a skeletally mature person, AP view with showing the pelvis and the femoral head appears to be deformed and with the neck widened, and the trochanter appears to be migrated proximally, and
Yes.
The lesser trochanter cannot be seen. And
Neck shortens.
beginning of the medullary canal also.
What is it? Anybody can talk. So many people are there. You can add, because otherwise it will waste. A lot of time is wasted.
There's acetabular dysplasia also.
Acetabular dysplasia. Why do you say that?
Because there is sclerosis of the margins and
there is sclerosis. That doesn't mean that it's dysplastic. There are changes which has happened in the acetabulum also, which is the other change that you see here.
Shallow. Acetabulum has become shallow.
Acetabulum is
and bicompass.
The shape of the acetabulum has changed, right?
Yes, sir.
Is it? It's the contour is cup shaped or irregular?
Irregular. Bicompartment.
It has become irregular, right? Not bicompartmented. You can't say that. Inferior part is not containing anything. Now we look at what else is you have to look at when you are looking at the acetabulum.
Widened teardrop.
Yeah, what is there is a widened teardrop. What is teardrop?
Floor of the acetabulum.
Inframedial.
So when it's a drop, it has got lateral, medial, and inferior border, right? Which are the structures? Which shadow is giving these three bodies? And which are the conditions where you get a deformation in this? Okay, now
quadrangular plate.
This, if I want to discuss it, I have to discuss it 1 hour on this.
The medial border of the teardrop represents the quadrangular plate of the acetabulum.
Yes.
Then the floor of the acetabulum is the lower portion of the teardrop. The outer part of the teardrop is the overlapping of the. No, sir.
Oh, doesn't matter. Anyway, you made an attempt. And all these findings, whatever you are talking is not correct also. So anyway, you go back and read about it. I am not going to discuss about that. Okay. Now, what has happened here in the head? Naomi said it's coxa magna. Why do you say that?
Because size of the head has increased as compared.
Yeah. If you look at so for that you have to compare with the opposite side, right? So apparently when you look at it, it has become a little more broader. That's all what you can say, right? It has become flat. And flat is congruous or irregular. That is what we are interested in. I was talking about irregular acetabulum. Okay. The outer border of the head is irregular or well contoured?
Flat.
Is it flat?
Regular.
So is it congruent with the acetabulum?
Yes, congruent.
Yes.
Sorry,
Congruent.
it's congruent.
Is congruent with the acetabulum?
No, sir. No, sir.
No.
So what are we talking about now? In Perthes disease, we always talk about this.
Stulberg's classification.
Stulberg classification. Okay. According to Stulberg classification, where does this stand?
Incongruent, congruent. Stage 4.
In which category you want to put this?
Stage 4.
Stage 4. Congruent acetabulum with incongruent femoral head.
Stage 4. What is 5? Is there a classification?
Incongruent acetabulum with incongruent head.
Stage 4 or 5, right? So both are equally bad. In the first classification, there were 5 types. Now some of the books show 4 types. Okay. So what is the one? Stulberg 1?
Femoral head is normal.
Femoral head is normal.
Femoral head is normal. What is 2?
The femoral head sphericity is maintained with a coxa magna or a coxa pequeña.
Coxa magna happens. What is 3?
Placed in one there is planning.
What is 3?
More flatter.
There is
It is oval and it is congruent with it. There is a congruous hip with flat head and flat acetabulum. So it is congruent. Then it becomes irregular. So it becomes 4 and 5. So it is either of these two. What is this line? What you are seeing here? Now we are talking about the head now. Now, what about the neck?
Short neck.
So what is called?
Coxa brava.
Coxa brava. What does it cause for the patient?
Coxa.
Coxa brava will lead to what in the gait?
Short limb gait.
Adduction.
Yeah, short limb and patient will have. What is the neck due? What is the function of the neck in the Trendelenburg mechanism?
Liver arm.
It is the liver arm.
Abductor liver arm.
So if it is short, what will happen?
Cause abductor insufficiency.
So it will lead to Trendelenburg gait. That is as simple as that. Okay. Now, what about this line which you are seeing? What is this line?
Sagging rope.
Huh?
Sagging rope sign, sir.
Why that? What is the reason for this sagging rope sign?
Is a metaphyseal response to the physeal damage.
What is Harris line? Thrust line? Is it same? So this is usual short note for you, So sagging rope sign was described by Appling. So you just go back and try to write at least one page on sagging rope sign and significance and the types of sagging rope sign. It is beyond here. Now, what do you find here in the diaphysis? Is it same here? Or is it different?
Widened canal.
Why it is widened? So possibly the surgery was done, right? Surgery was done. It was a possible. What is the possible surgery which was done at the time? Is it the same line or there is a varus angulation there?
Varus angulation.
Yeah. So what is it? So it was axor varus osteotomy. And here, because the age group was 11 years, what has happened here? 11 years, is it the right time to do the axial varus osteotomy?
After 12 years.
After 12 years. What is the purpose of axial varus osteotomy?
Containment effects.
So when you do contain?
After
before the epiphysis fuse.
Before the epiphysis fuse, there is a time when you contain? Anyway, I think you have to read all those things. These are fundamentals in orthopedics. You can't escape from this. Right? The containment is done. Yes, Nami?
7 to 12 years, sir.
Sorry?
Before. Sir, age-wise?
Before 8 years.
Should be done early, right? In which part, which stage of Perthes disease you should do that? Up to one particular level, you can do that. After that, you are not.
2A.
What is 2A?
Age 2A.
What is stage 2A?
That is the fragmentation of the epiphysis.
Early fragmentation.
Only 1 or 2 filters are present.
Yeah, see, it should be done before the late fragmentation phase. That is 2B. 2B is late fragmentation. So you have to do up to 2A. What is 1A and 1B?
1A, stage 1, when the epiphysis is avascular. So 1A is when there is no loss of height of the epiphysis. 1B is there is some loss of height.
Right. So it is not after the epiphyseal fusion. It is not in the late stages. It should be done early, and the age group is around 8 years. Right. You are not supposed to do the surgery at the age of 12 years. Containment is not the surgery in 11 years. Number one, and that is why all this problem happened. The containment surgery which is done was late and not at the right time. That age, you are not supposed to contain the hip even. And in females, the Perthes disease is late onset. And late onset Perthes disease clinically appear like a arthritic hip. That is the usual classical description. So it's only observation and exercise, nothing more than that. You are not supposed to contain a hip. The surgery should never be done for containment in this particular case. That is the answer. So when that was done, all the complications that you are seeing here for the patient is as a result of a wrong surgery done at the wrong point. That is why all these things happen. So it's very important that we learn all those things. That is, we will not commit these mistakes. Okay, now we'll go fast, and because it is time now, I have finished by 9:30. I finished. Okay, so now you look at the lateral view. What has happened to the lateral view? Yes, anybody can answer. Why we want to waste? Yes?
There is a hinged abduction.
Yeah, there is hinging. And not only hinging, you can see the hinge abduction which is happening. The head is in the AP view. Before that, what you found is it was well contained inside the hip, right? So now this has come out of the hip. You see that the gap, medial gap is opening up. And the shape of the head is abnormal. The APV we could not make out. But when you are abducting, the hinged abduction is beautifully seen here. So what does a hinged abduction means? What is the reason for hinged abduction?
Hump. There is hump. There is the head that.
Why that develops? It develops because you don't have enough of abduction at the time when you do the surgery. Understand? So the head subluxation was not corrected. That is the reason why this has happened. Again, another decision making which is gone wrong. So I'll show you This was the surgery done. See, I have the X-ray for that. What does it tell you? You can see the epiphysis, right? This was so many years back. And what is the surgery done for this patient?
Valgus
rotational osteotomy.
Yes, it is virus. Whatever we were talking about is Axer virus osteotomy that is done. And you can see there is a translation which has happened. Number one, the head is in varus position, right? You can see the trochanter which is moving towards the pelvis. And how much of angulation you should give in a case of Axer virus osteotomy is you should never give more than 15 degrees of angulation. So your plate should be bent 15 degrees. You should not go beyond that. You understand? So here again that has gone wrong. And the neck shaft angle after the surgery should be about 115 degree. It should never become less than that. If you do that, again, all the problems will happen. And you can see again, the deformity is not remodeled in this case because the remodeling chance is not there in a female who is 11-year-old. That itself led to shortening. So there is a compounding problem which happened because of a surgery which was done not according to the indications, not according to the principles. That is why all these things happen. Okay, now you see the knee. What has happened here in the knee? You can read this now. So clinically you have seen there is a valgus deformity. There is a posterior subluxation. But do you see a posterior subluxation in this case? Oh, sorry. No, but what is the deformity there?
It's flexion.
Flexion deformity.
That flexion deformity. In tibia, you look at the tibia now.
The slope.
And
yeah, the slope is reversed, right? And there is an angulation here, right? There's an angulation here. This is one common complication that we used to get in children as a result of our treatment. Which is that treatment? The anterior part of the epiphysis is not growing. Posterior part is growing. Naturally, there will be a recurvating type of deformity developing. And which is the condition or which procedure in our usual management can lead to this in a child? If you are using tibial traction, understand, if you are not correctly putting the tibial traction, just like the adult, if you are doing it, this will happen. And tibial traction in a child, due to so many conditions, we give tibial traction. You have to use K-wires and very thin wires, and it should be, if you are using a Steinman pin, it should be much below this level. So that is the common thing. Which is the other problem that can have? That is infection. Okay, in this particular case, we don't know what has happened actually. So this is what happened. Then valgus deformity as a result of. Can you get a compensatory deformity, extension deformity, due to any reason, which knee goes for extension during the growth phase? It is a compensatory deformity. Which is that condition, and when will you get it? I think I have shown this video 1 year back. When in Anowski, a patient is walking. This patient is in our hospital, in fact.
Post-polio.
Yeah, post-polio where? In which condition of post-polio?
Short limb.
No.
Hand to knee gait.
When will you go for hand knee gait?
Hamstrings are weak.
Then quadriceps muscle is weak. So that is the condition where you can have a recurvating deformity. Equally possible when another stance face muscle is weak, which is that muscle. There are three muscles which act together. One is corticeps.
Yeah.
There are two other muscles. Which are they? One is gluteus maximus in the hip. Okay. Then stabilizing angle, calf muscle. If the gluteus maximus muscle is weak, what is the gait that we have? What is the gait known as? Gluteus maximus gait. How does that patient walk? That patient will thrust the knee backwards.
Crouch.
Not crouch. It is not crouch.
Posterior lurching.
Yeah, the patient will thrust the hip forwards, thrust the knee backwards to stabilize while walking, and that also can lead to this type of deformity. So here it seems we are not very sure about it, whether the tibial traction was given at the time of this, we don't know. But as per the history, skin traction only. Okay, so what will you do?
Valgus.
The patient's complaint is limping and pain, sir.
Yeah.
So our goal.
But you can see that patient is walking, not with much pain, right?
We can counsel her for a delayed procedure later. If
what delayed procedure?
Correcting the hinged abduction. So correcting the hinge valgus derotation.
Valgus derotation osteotomy. So when is it indicated? But these are all to be done early, right? Now it's a question of reconstructive surgery.
He's 28 years old. 20.
Yeah, now it is 20. What is the age? 24.
28.
What is the age?
28 years, I think, sir.
28 years. So you, at this phase, what advice will you give? Do you think that there is a change which is happening in the hip on the acetabular area with sclerosis?
Yes.
Possibly she's, what about the joint space now? Not that narrowed, right? So eventually what is going to happen for this patient? This patient is going for a second osteoarthritis.
THR.
Yeah, she may be going for a THR subsequently. So we have to delay that process, number one. So the next problem is regarding the knee and the shortening. Can you do something for the knee?
Correction osteotomy can be done.
Yeah, you can do a corrective osteotomy and you can even try for a lengthening. Okay, so maybe the plan can be in this route for the tibia and correcting the length and trying to correct the deformity. That can be plan for this patient at present. If you have to counsel the patient that this is the way that we can do. For the hip joint, go to wait. You may go for an arthroplasty at later phase, and if pain is that severe, then we will consider that at that point. So that the way that you have to discuss these cases. I think I have not heard so many things. Some points I wanted to give. What is the gait? Then reading an X-ray, and the prerequisites for an axillary varus osteotomy. What is the age? And when containment happens. Containment, what does it mean? Containment means the head should go inside. But the age group and the stage of the disease all decide. So go back and read about the indications for axillary varus osteotomy, how is it to be done. Because this case can be shown even in an X-ray and they can ask you all questions. But complications that you saw here will not. So this is a classical typical case. And in fact, to all the Amrita students, I can tell you this is the case that was kept for last exam. Anyway, you will not get this case. Don't worry. These are the type of cases that is kept. So can we close it, or you want to ask me any question? You can ask, and we'll close. Okay, we'll do it. As you know, teaching, anybody ask me, I'll be always there.
Okay. Thank you, sir. Thank you. Good night.
Good night.